topic for today is acute coronary syndrome, and this is what we'll be discussing. So, what is ACS? ACS or acute coronary syndrome basically encompasses a whole spectrum, right, from unstable angina up to ST elevation MI. Okay, most of my presentation is based on the 2023 European Society of Cardiology guideline for ACS, and we'll be discussing the fourth universal definition of myocardial infarction, which has been defined by the American Heart Association. Okay, it is important to know the guidelines because there is one fixed way of going about with the treatment of these patients. Okay, so that is why we'll discuss the guidelines which revolve around the topic. So ACS, okay, that is a first three things that you should assess for the initial assessment of the patient. One is abnormal ECG. C is a clinical context, your presentation, and S with the stability. If you have an unstable patient or a complicated or a unstable patient. Okay. So what are the invasive line of management? So basically, it is either stenting or you give fibrinolysis. That is, you give medicines to dissolve the clot. So that is fibrinolysis. When do you do which treatment? Is what we are going to study as we go through this lecture. Okay, what is a long-term maintenance plan of these patients? What if the patient doesn't reach the hospital on time? What is the overall approach that a cardiac patient should maintain once the stent is in situ, if the patient has undergone a bypass surgery? This is all what we are going to discuss in today's lecture, and this is just a short summary of what we'll be talking about. Okay. So let's begin. Symptoms. So this is how most of your patients will present. So it will either be with a classic chest pain or pressure, which is retrosternal, central. Okay. They will just say that there is heaviness in the chest, or there will be sweating. Most common, what you will see, or people might, call you and say that relatives very commonly call up and say there is some kind of acidity which is not settling with the regular set of medicines. I don't know what is happening. I don't feel good. It's such a vague complaint, but very important to ask these patients to reach emergency as soon as they can. Okay, epigastric pain or indigestion is a very, very common symptom or feature of this MI. Okay, shoulder pain, arm pain, dizziness, nausea, vomiting, again associated with some amount of epigastric pain, jaw pain, neck pain, okay, radiating to the left jaw. This is all on the left side, or sudden shortness of breath. Okay, so this is how your patient can present vaguely, whether they are doing activity, whether they are just sitting at home, whether it is in the middle of the night. At any time, these symptoms can present. And any patient of chest pain, any patient, even if it is not very severe, the pain, but suspected chest pain which could be pointing towards MI, it is always better to send such a patient to the emergency so that their ECG and troponin levels are checked. And that is what we are going to discuss in the lecture, that how these two things are so important in the diagnosis and help in deciding your line of management. And why immediately? Because this is one topic which if you have to talk about in one line, the time is life. Time makes a big difference. That is why any patient who presents to you, you have to send the patient to emergency or get the treatment started immediately. Okay, so so we spoke about the spectrum which spreads from unstable angina to STEMI. Okay, so what are the three main things that we'll be focusing on is any changes or any new signs or symptoms, ECG, and cardiac troponin concentrations. Okay, ideally when the patient presents to you, your ECG has to be within the first 10 minutes of first medical contact. Okay, first 10 minutes. And your cardiac troponin levels should be in your hand or in the hand of the emergency physician within 60 minutes, because that is how important it is for the practitioner or for you to take the decision and to start the treatment immediately, and which is going to make a significant amount of difference. So now we're talking about the spectrum. So what do you mean by unstable angina and what do you mean by NSTEMI and STEMI? Okay, so unstable angina is nothing but pain or ischemia which happens at rest or minimal exertion. Okay, sudden in onset, and there is no acute myocardial injury. Okay, it is prolonged angina at rest. It is new onset. It increases in frequency, long duration, or lower in threshold. Okay, dull pain kind of a thing, and it can occur after a recent episode of MI. Okay, acute MI is when there is myocardial injury which is responsible for the cardiac troponin release, and this is the classification of acute myocardial infarction is based on the fourth universal definition of MI, which we'll be discussing in detail after a few slides. Talk about STEMI and NSTEMI, which you must have heard. So STEMI is ST elevation MI and NSTEMI is non-ST elevation MI. So let us just go through that, read about that in detail. Okay. So what is this ST elevation MI? So can you see this J point, which is the ST segment? Okay, P, Q, R, S and your T wave. So this ST segment where it begins is the J point. So the elevation of J point in at least two contiguous leads. Okay, so can you see here? Okay, 2.2 mm, 1.5 mm. Okay, depression by 1.8 mm. You know how to read the ECG, right? So each small square vertically is 1 mm. Okay, so that is how you can measure how much the elevation or the depression. So when you have more than 2.5 mm in men less than 40 years, and you have a lower threshold for men more than 40 years. Okay, and more than 1.5 women in women regardless of age in leads V2, V3. Okay, and or more than 1 mm in the other leads. Okay, then it is all pointing out towards ST elevation MI. Generally, ST elevation more than 2 mm. If you know, all of this is difficult to remember, just one basic, more than 2 mm ST elevation is considered as significant. ST elevation is always due to transmural infarction. So all your layers of the heart are involved. Okay, so whenever there is an ST elevation, it is always suspicious. Okay, always. So this is how your ECG will change. Okay, so as soon as the pain sets in, you may not get the classic changes in the ECG. All you'll get is a hyperacute T wave. Okay. After this, it is followed by ST elevation. Okay. Then comes the Q wave. Okay. Once your Q wave sets in, then gradually after a few days, okay, your ST elevation starts settling down. This is in the absence of treatment, of course, and you get an inverted T wave. And weeks or months, so that is your eventually when you have to say it's an old MI, what you're going to get is presence of Q waves. Okay, presence of Q waves is, what is suggestive of an old MI which has probably undergone all these changes. So now when we say MI, we need to know which, so all vessels are not involved at the same time, not necessarily involved at the same time. Okay. So depending upon which coronary artery is involved, you are going to get that wall of the heart is going to show the changes because the blood flow to that part of the heart is going to be affected. Okay. So when we say anterior wall MI, okay, ST elevation MI. So where are we expecting the changes? We are expecting the changes ST elevation with subsequent Q wave formation like we described in the precordial leads V1 to V6. Okay, this entire thing and plus minus high lateral leads. So we are talking about 1 AVL. Okay, so can you see here that the elevation is here, elevation is here, elevation is in V2, V3 and V4. Okay, so it is often preceded by hyperacute T waves like we mentioned. Okay, whenever you get ST elevation, you get reciprocal depression in the opposite leads. Okay, so opposite to the anterior will be the inferior. So can you see in 3 AVF? So not so prominently in AVF, but in 3 you can see definite ST segment depressions. Okay, some depression in lead 2 as well. Okay, again inferior lead. Okay, this is anterior wall MI is most common.